Welcome, everybody. My name is Dr. Tom Brophy. Many of you know me from working alongside of me in the emergency department. And although many of you know that I'm board certified in emergency medicine, what you probably don't know is that I'm also board certified in addiction medicine. And because of that, I have been asked to do a little bit of an education program for everybody as far as addiction, what's happening in the brain, and more specifically, when we're working in the emergency departments, what are some appropriate ways to manage some substance abuse patients in the outpatient setting. Now, in the emergency department, as many of you guys know, we see a lot of issues that are related to alcohol abuse, cocaine abuse, heroin abuse, all of the above. But there are not always clear-cut instructions on how we should be managing these patients in the ED. So we are going to start with some objectives. We're going to talk a little bit about the neuroscience of addiction, and specifically, I'm gonna talk about it all in relation to opioids, because I think that gives people the best understanding of how you can extrapolate that out to other substances of abuse. But then we're going to talk why this neuroscience physiology matters. Why is it a little bit different than the other things that we manage in medicine? And then finally, outpatient management for the ED provider. I know you guys get bombarded with education. You have to keep up with all of your CME. You have your employer training certifications, stroke certifications, ACLS, PALS, all that kind of stuff. And I'm not trying to bombard you with stuff that's going to, be more load piled onto that. My goal with this is to do a quick 20 to 25 minutes and give everybody something that they can take with them that's useful in managing these patients. So you guys can all let me know if that's actually a goal that I've accomplished. Okay, this is the Papaver somniferum plant. You can't see the tail end of that word, apologies, but this is the plant from which most opioids come from. You guys probably know that. About 2/3 of all opioids come from this plant. It is the glue inside that little bulb that's dried out. And while about 70% of opioids come from that source, there are about 30% of them that are synthetic, meaning they're made in a lab, of course. But this includes drugs like methadone, and particularly fentanyl and carfentanil. And we almost never see heroin anymore. At my treatment facility, where we screen people with forensic level labs, I'd say it's been about 6 months even since I've seen pure heroin. It's always fentanyl, almost always, because it's so cheap to purchase and cheap to smuggle. And like I said, it can be made in a lab by a good chemist. So classic opioid toxidrome. This was something that I was asked as a medical student. It was one of the first questions that I was asked. And I remember standing up in an auditorium with a very, a professor who was very intimidating. And he asked me this question in front of the entire class. But what he didn't know is that my brother was actually already struggling from substance abuse, and I had a particular interest in substance abuse prior to that. And so thankfully I was able to answer the question well. But there's a toxidrome for every substance that's abused. There's an alcohol toxidrome, a benzotoxidrome, an anticholinergic toxidrome, and of course an opioid toxidrome. The opioid toxidrome is decreased responsiveness, decreased respirations, and pinpoint pupils. You guys all know this, but a couple things just to kind of drive home is it's the decreased respirations, of course, that kill you. The body does not go into cardiac arrest from heroin. It goes into respiratory arrest. Your organs then survive on that residual oxygen that's circulating through the bloodstream. However, then as you get that end organ dysfunction from the hypoxemia, that's whenever the patients often go into cardiac arrest. So that time from when their breathing has failed and before they've gone into cardiac arrest, that's the best time to administer Narcan, because it won't require likely much CPR. You'll be able to give the medication, knock those drugs off the receptors. We'll talk a little bit more about that later, and avoid doing chest compressions for CPR. But it's actually the pinpoint pupils that's the most interesting. And one of the things that I talk about often is a case. Some of you guys have heard me discuss this in the ER, but I've taken care of 4 babies that have overdosed on opioids over the past decade. They've ranged from a mom putting Suboxone into the mouth of a baby. One in Northside, we had a baby that stumbled across a methadone tablet. And more recently, actually, about a year ago, I was doing locums. I was down in West Virginia, and there was a woman who had brought in a baby and later admitted to giving that baby heroin. The diagnostic clue that made me give that baby Narcan was pinpoint pupils. As you guys know, there's not a lot of things in medicine. There's some rare strokes and some things that will cause pinpoint pupils, but the nurse was carrying this floppy baby and running down the hallway. And you know, you guys have been in this setting before. You're busy. There's a lot of alarms going off. And I hear, Dr. Brophy, I need you in the resuscitation bay. And I see her carrying a limp baby. Well, I immediately went into the room. I'm securing the airway. Somebody else is securing an IV. I happen to be looking over the baby for signs of trauma and physical abuse. And I saw the pinpoint pupils. So that was the giveaway. And mom later admitted to giving that baby heroin. And while the pinpoint pupils is, of course, important to discuss, it's also important to discuss how did that woman navigate life normally for 30 years? And she had a job, she had a college education, she had a spouse, and she had other kids. How did that normal functioning brain get to the point where, you know, doing something as egregious as putting heroin into your own baby was even a consideration? When we talk about the neuroscience of addiction, which we're going to do over the next probably 8 to 10 slides, this is what I hope to educate you on, how that dramatic change happened and why we're seeing that behavior as a result of those neurophysiologic changes. So that all starts with this slide, which is, this was actually taken off of the NIDA website, the National Institute on Drug Abuse. And it shows where opiates are having their strongest concentrations and highest effects. So you can see the little green dots there, and you can see that there's some up along the sensomotor cortex. There is a cluster in the middle part of the brain, or what's called the midbrain, and then you see some along the spinal cord. Of course, important in noting that there are other areas that are affected, such as, you know, your motor activity and your pain reflexes in the spinal cord, but the main cluster is in that middle part of the brain. That red line that you see going between two anatomical structures there, that is the nucleus accumbens and the VTA. And those are two areas that have been specifically pinpointed in the medical studies as important aspects of the limbic system that are involved in driving these addictive processes that we're going to talk about. So what is that limbic system? Good question. I know these cartoons are a little bit childish. This is what I use whenever I go and I'm educating like high school and college kids. What is that limbic system typically responsible for? So my background is in neuroscience. Some of you guys know that. The limbic system is a very, very complex portion of the brain. And I don't mean to simplify it in such generic terms, but for understanding addiction, this is the best way to do it. Your limbic system is primarily what I call the caveman portion of your brain, because this is what got us out of the caves and sort of moving forward in evolution. And anybody who does not do these 4 activities typically doesn't survive on the planet for very long. The limbic system is involved towards driving you towards food, water, sex, and shelter. Again, crude generic terms, but basically nourishment, procreation, and safety. Food and water, of course, nourishment, the sex, the whole process is designed for procreation and passing on your genes. Shelter is really generic for safety from your environment, from predators, from all of those things. So in essence, your limbic system is what's keeping you alive in relation to those things. How does your brain drive you towards those behaviors? Through feelings of pleasure, reward, and happiness that we feel. Those feelings of pleasure, reward, and happiness are specifically coming from the 2 neurotransmitters. One is called dopamine and the other is called serotonin, and we'll get to that shortly. But the other thing to really understand here is that the prefrontal cortex, that where the green arrow is on this slide, that's the part of our brain that sets us aside from primates. Evolutionary speaking, it's the newest part of the brain, and it's also where all of your complex rational thoughts come from. So, you know, deciding between short-term consequences and long-term gains, deciding between, you know, something that is very analytical or requires reason and logic. You know, do I want to pursue this course in medicine? Do I want to pursue that course? And as physicians, as PAs, as nurse practitioners, like as providers, we're all using that prefrontal cortex all the time, right? Well, the limbic system is a much older part of the brain from an evolutionary terms. And not only is it involved in food, water, sex, and shelter, but it's also very, very intimately tied to emotions and instincts and motivation and impulsivity. And that's why we see dysfunction in all of those things whenever it comes to substance abuse and addiction. But there's another really important distinction to make. And that involves understanding the hierarchy of the brain. You can go to the next slide. So this differentiates the parts of the brain from an evolutionary standpoint. The further back you go down to that brainstem and pons and medulla, that's called the reptilian part of your brain. Why? Because from an evolutionary standpoint, it predates mammals. You can trace it back to reptiles. Then you have your midbrain, which is called the paleomammalian brain, because that's whenever it evolved. And that is responsible for the things that we discussed. And then you have your new brain, quote unquote. In the world of neuroscience, that is referred to as the neocortex, because it's the newest from an evolutionary standpoint, and it makes up that outer shell, that cortex. Understanding the hierarchy of the brain is a very important thing in the world of neuroscience. And we don't talk about it that much in medicine, so I wanted to take a little bit of time to understand it. And the best way that I can do that is by example. Okay, so we're going to start off with a patient who is really, really hungry and really, really thirsty. Now, some of you may have seen me drinking from my bottle of water here. Nobody really cares, right? Why don't you care? You might have a bottle of water sitting right next to your laptop. You may have had a bottle of water an hour ago, but the point is you're well nourished and you're well hydrated, so you're not thinking too much about my bottle of water. However, if we stayed in this exact same scenario and in these same seats for the next 4 days, I would be activating your limbic system to the point that you'd look a lot like this angry guy, and you would be obsessing about my bottle of water. You wouldn't be able to listen to this lecture. You wouldn't be able to, work on your CME on the side, pretending to listen to this lecture, or any of those other things. You would be obsessing about my bottle of water, because now that limbic system is overpowering that prefrontal cortex that you were using for all of those analytical and reasoning and learning type of thoughts. So, because of this, because this person in this picture no longer has that nourishment in their system, their limbic system is overpowering any thoughts about the prefrontal cortex. The reason why this is important to understand is because when somebody is struggling with substance abuse and they are involved in that dysfunction that's wrecking their lives, if they've had drugs recently, or even if you just catch them at the right time, they will sit down and they will use their prefrontal cortex and they will tell you all the things that you hope to hear. I don't want to continue doing this. I don't want to be a drug addict anymore. I've destroyed my life and I don't want to continue destroying my life. However, when they walk out of that room, it is similar. Try and think of it as you being without food and water for 4 days. Their limbic system has been essentially hijacked by this substance that they're abusing. And it is providing dopamine waves in that limbic system that are bigger, stronger, and more powerful than anything that you achieve naturally from, eating some toast and drinking a bottle of water. We all know that if you haven't had those things in a while, it tastes like the best bottle of water you've ever had, right? That has to do with the limbic system. Imagine what that's like on a scale that's 1,000 times larger than anything that you're experiencing naturally. So they will use their prefrontal cortex and they will agree with you, and they'll be truthful and meaningful in those statements. However, whenever they walk out, that chemical imbalance is something that is so powerful that they can't control it. We can take this a step further by going back to an older part of the brain. Say that same gentleman is sitting there and he's hungry and he's thirsty and he's angry and he's ready to kill me for my bottle of water. Well, if I put a plastic bag over his head, he immediately stops thinking about my bottle of water. Why? Because now we're talking about the brainstem. We're talking about the things that are responsible for, your oxygen hunger, your carbon dioxide levels, and your vital signs. Is truly the things that are keeping you alive in that moment-to-moment sense. This guy's not thinking about my bottle of water, because if he doesn't get that bag off of his head, he's not going to be alive to drink the bottle of water. So that makes sense. But really what I'm trying to demonstrate here is that hierarchy of the brain. The older parts of the brain overpower the newer parts of the brain, which makes sense because it kept your species alive from an evolutionary standpoint up to that point. This is a big reason why the cycle of substance abuse just continues. People can rationalize through it, but it's just neurochemistry and old neuroanatomy and neurophysiology that's driving that process. Okay, so the surges in dopamine, serotonin, we're not going to talk too much about those. You guys know those are the chemicals that are mainly responsible for motivation, happiness, and particularly dopamine is the one that's involved in substance abuse and addiction. I do want to talk a little bit about this. Why don't we just have a country of Vicodin addicts? Why does everybody progress from oxycodone and hydrocodone to heroin? Well, that was a question for me when I was watching my brother's life and trying to figure out like how this all happened. These are the two main reasons that that progression happens. The top slide is morphine on the left, heroin in the middle, and codeine on the right. And at first glance, you can barely tell the difference between those molecules. Why? Because they're so close in structure. There's that little carboxyl group in the upper left hand that is a very important chemical compound of or component of that compound, because it dictates potency and how much of that dopamine goes through. Certainly morphine and codeine are not having the same effect, but they are docking into the same receptor. Your brain doesn't recognize a difference between those things other than the dopamine wave that it produces. But they're essentially binding the same thing. So that morphine and heroin, they're all getting broken down to a molecule that's binding to the same opiate receptor. There are several opiate receptors, OR1, OR2, and so on. Then there are subcategories like the mu, the kappa, and the delta. We're not going to cover a ton of that stuff today, but designing medications that work specifically on those various targets is a part of treatment. So we'll touch upon it later. The other big thing that drives that process, though, is tolerance, opioid tolerance. And you guys all know what opioid tolerance is, but when I'm explaining it to other people, I basically tell them like, hey, if you broke your femur in the ER today and I give you a Percocet and it reduces your pain, well, if you continue taking Percocets, 6 months from now, it's going to take 3 Percocets to get that same pain-killing effect. Maybe a couple years from now, you're going to have to go from Perc 5s to Perc 10s, to Oxy 15s, to Roxy 30s, and so on and so forth. And this is that progression of opioid tolerance, which is what ended up being such a bad idea for chronic pain management, because there's nothing to do other than keep scaling up those doses as the body becomes accustomed to it. Okay, so this is just a slide that I have up a lot of times when I'm trying to show people the dramatic changes. It's all the celebrities we love to hate. You got Macaulay Culkin, Tiger Blood, Charlie Sheen in there. But the reason why I put this up is because we've talked a little bit about the hierarchy of the brain, and we've talked a little bit about neurochemistry. But me looking at my brother, me looking at other people struggling with addiction that I hadn't seen in 10 or 15 years, there seems to be more to it. There seems to be more to just hierarchy of the brain and chemical surges. And we actually know now that there is. Neuroplasticity is like the hot topic in neuroscience right now. And a good way to understand neuroplasticity is just to understand that we're not fixed, rigid subjects. Most of you know that by now. You've worked in medicine. You know that bones bend over time, and your body is constantly changing. Even the slow changing things that we didn't recognize as changing before. Previously, it was thought that the way you're wired is the way you're wired. We now know that that's not necessarily the case. I often give an example using these pictures as neurons. The picture on the left is what you see in Marvel comics and superhero movies, but the picture on the right is taken directly out of a neuroscience textbook. That's the different types of neurons, but they're all basically the same. They have a cell body, then they have an axon, then they have a bunch of little dendrites or branches that are communicating with other neurons. The signal is a chemical signal in between two neurons in that synapse, and it's an electrical signal as it's traveling down that axon, and it's happening through the influx and efflux of sodium and potassium, which is what gives you that electrical charge that propagates down that axon. Understanding neuroscience is really similar to something like this. I'm going to give you a scenario. Say you walk outside today and the sun hits your face and a warm breeze hits you in the back. That feels good, right? You know it feels good, and you know that you got a little squirt of dopamine because that's the feel-good chemical, right? What neuroplasticity says is that in addition to that little squirt of chemical, of dopamine, and in addition to that electrical signal, that there's actually physical changes that are going on in the brain. So that could mean one of these neurons in this diagram disconnecting its dendrite from one neuron and sending out a new dendrite to connect to another neuron. But over time, there are physical structural changes of these neurons in the brain. That's neuroplasticity. It's also the explanation behind, you know, why does practice make perfect? Like, it's not all muscle memory and fine tuning your coordination. It is neuroplasticity that is driving that process of making you better and better at that thing. Well, in a dark way, it makes a drug addict a better and better drug addict. Because remember, the brain, from an evolutionary standpoint, it's not differentiating between different, you know, drugs that cause the dopamine. It's differentiating between how big is that dopamine wave. And the ugly truth is you cannot get a dopamine wave naturally as high as you can get from abusing illicit drugs. And so their brain is continuing to chase that behavior. Hey, let's do more of that again. Over time, they become better at dismissing the concerns. They become better at manipulating their environments. They become better at everything that has to do with them accessing that drug more and more and more, and setting all other concerns aside. And that neuroplasticity is how we get from, you know, that young Charlie Sheen to Tiger Blood. Okay. This is, I just put this up there so you guys know, this is not Dr. Brophy's theoretical neuroscience lecture. You know, this is proven. We can look at functional MRIs. We can look at one and even say like, oh, that's a drug abuser. And that one is somebody who doesn't appear to be struggling from severe substance abuse. In the past, it was, you know, this is your brain and this is your brain on drugs. There were even other times that were worse where they would say like, oh, this person is a drug addict with that brain because they have a broken brain. That's why they abuse drugs. We know now that that's of course not true, that everybody starts with that healthy brain. Well, most of us, and it's the damage and the dysfunction that results on the brain on the right. That's just a general neuroplasticity thing. But now let's talk a little bit about treatment. Okay, so we can extrapolate that limbic system, that neurophysiologic hierarchy, we can extrapolate that to other substances of abuse. They're all involving the limbic system. Many of them are involving dopamine. But let's talk about some of the things that we're going to encounter in the ER. There's been a push recently for medication-assisted treatment, and to the point that medication-assisted treatment has now become the gold standard. Even when the Obama administration put forth $4 billion for the Century Cures Act, or the Trump administration put forth billions of dollars, you know, against the opioid epidemic. All that money is going to places that support medication-assisted treatment. Why? It's a great question. People come in all the time and they'll ask me like, wait a second, you're talking about things like methadone, Suboxone, Vivitrol. Isn't that trading one addiction for the other? It's not. It's trading addiction, which by definition is destructive, for a stable chemical dependence. If they're going to the right facility and are being guided by the right medical providers, then that's a trade-off that's worthwhile because you stabilize their life and then over time you get them off of that medication. But the reason why the government puts all their money into MAT is basically these statistics here. It's a hard thing to swallow that abstinence is only 3 to 5% successful. Ideally, even the addicts coming in, they don't want to be put on methadone or Suboxone or any kind of medication. And that's true for alcoholics. They don't want to take disulfiram every day. They don't want to take Camprol or naltrexone. We'll talk about all those shortly. They see this as a ball and chain. They want to break loose of that ball and chain, and they don't want to be tied to something else that they have to do every single day. This is where it's explaining to them that we're stabilizing that neurochemistry so that we could actually like work towards achieving our goals in treatment. But when you look at something like abstinence that has a 3 to 5% success rate, and then you look at MAT, which is 10 times more successful and sometimes even more, that's why they're putting all their money into those proven methods. So what type of MAT exists? Well, for every substance that's abused, there's some MAT, or at least some theoretical MAT. This is true for tobacco abuse. We use Chantix, we use Wellbutrin. We replace the chemicals with nicotine patches. Then we slowly work towards weaning down those nicotine patches. It's similar in all substances of abuse. But in general, it's either agonist treatment, partial agonist treatment, or antagonist treatment is what meets the definition of medication-assisted treatment. Once you get into things like naltrexone for alcohol, it's not really working as an antagonist as it is an opioid. So it's not always clear cut, but we'll talk about some of that as we're moving forward. We talked a little bit about this, the subtypes of the opioid receptors. It's the mu receptor that's giving you euphoria. Buprenorphine, which is the active ingredient in Suboxone and Subutex and Sublocade and Bunavail and Subzolve and all those buprenorphine products, it's actually working more at the kappa and delta receptors, which is why people don't get high on Suboxone. The only person who's going to get high on Suboxone is someone who's opioid naive. It's a partial agonist, which actually we'll be getting into that here shortly. Full agonist treatments, the ones that we had talked about at the top of this list, full agonist. Methadone maintenance is really the only one that exists in the United States. There are other countries that actually do things like heroin maintenance and fentanyl maintenance. Whereas, you know, in Canada, people can go to Vancouver and they can go to a safe injection site where there are clean needles and counselors to help and Narcan to reverse their overdose. But there's also treatment available for people who would then decide that they've had enough of that and they wanted to go into treatment. In some countries, there's actually like heroin maintenance programs and fentanyl maintenance programs. We don't have anything that far ahead or progressive or extreme in the United States, but there is a lot of talk about doing safe injection sites in Philadelphia and San Francisco, and a lot of times they're looking at the safe injection site in Vancouver for that data. But those are examples of full agonist treatments. Partial agonist treatment, the only one that really exists is the buprenorphine products, but there's various compounds and ways in which those products are put together. The two that I want to talk to you about, which are the main two that you would be prescribing as sort of a warm handoff from the ER, are Suboxone and Subutex. Both of them have buprenorphine. The Suboxone also has naloxone in it, while the Subutex does not. Why? Well, it's really important to understand that that's mainly in there as a deterrent for abuse. So when someone takes a Suboxone, like you can see an orange tablet in the middle and a film strip, an orange film strip on the right-hand side there. When somebody puts that under their tongue, because of the bioavailability, they absorb a large portion of the buprenorphine and a very, very tiny portion of the naloxone. It's still in their system because we can detect it on forensic level drug screens. But the buprenorphine is dramatically outweighing that naloxone. So they're getting the effect of the bupe. If that person were to dissolve that Suboxone on a spoon, draw it up with a syringe and inject it, they would get the majority of the naloxone and they would get very, very low levels of the bupe. So it is truly in there simply as a deterrent for diversion and abuse. But people love Subutex, and people are going to come in just like they do to my clinic every single week. People come in and they're requesting Subutex, and they're telling me all sorts of reasons of why they can't take Subutex, the most common being that they're allergic to naloxone. Now, the reason why Subutex is so highly coveted is because it can be snorted and it can be abused. Or even in somebody who's stable in their recovery and treatment, it has a $30 street value. So giving somebody a prescription for a month's worth of Subutex, and they look at that as these are 60 Subutex tablets. I can control my withdrawal symptoms and my recovery with 30 of them. The other 30 I can sell for $30 a pill. That's a mortgage payment for a lot of people. So of course they're seeking Subutex. But the truth is Subutex is only meant for pregnant females. It's only meant because we don't have good data on how that tiny bit of naloxone that gets absorbed in the Suboxone or Subzol versions, how does that affect the baby? Well, we don't really know. So the only people that we put on Subutex in my clinic is pregnant females or anybody who truly has an allergy with documented antibodies to naloxone, which I've never seen. And you guys have all given Narcan or some form of naloxone or naltrexone to how many patients? When was the last time you saw an allergy? It just doesn't exist. So please be aware of that. The Suboxone is the safer and less diverted option. The Subutex, particularly if you get out and start prescribing that as like a treatment provider, it's a big red flag, and I strongly encourage that you do not do that. Examples of antagonist treatments, of course, Narcan is the one that we use all the time in the ER, and that's short acting, which of course you all know because we always have to worry if somebody rips off those leads and rips out that IV and walks out the door, is that naloxone going to wear off before they do drugs again, or even before the long acting drugs wear off, and it's a real concern and a real possibility. The long-term version of these medications is naltrexone. Naltrexone comes in two forms. The oral form is called Revia and the injectable form is called Vivitrol. And naltrexone has been approved for both opioid use disorder and alcohol use disorder. Only in the opioid use disorder is it actually functioning as an antagonist where it binds the receptor and blocks everything else. It's kind of interesting little side note. Why is it working in alcohol? Well, when they were studying the effects of people to get it approved for opioids and alcohol, what they found is that almost everybody, regardless of whether they had substance abuse history or not, almost everybody reduced their alcohol intake. And it wasn't really understood well at the time because, as many of you know, alcohol binds to the GABA receptor. It's not binding to the opioid receptor, right? So then how does naltrexone work in alcohol use disorder? What they have since found in the world of neuroscience is that somebody that is taking naltrexone, say they're coming in and I'm giving them a Vivitrol shot for their opioid use disorder. Well, that same person over time will lose interest in consuming alcohol because we now know that while a lot of the negative effects of alcohol are happening through that GABA receptor, which explains their respiratory suppression, their motor suppression, all those downer aspects of alcohol that we see, that little pick-me-up that you get from alcohol, starting from that initial buzz, which makes you feel great, all the way to all of your problems melting away, well, that's all happening in a secondary mechanism through the opioid receptor. So when you block that opioid receptor, they get the negative effects of alcohol consumption. They'll still get a DUI, they'll still be impaired, they'll still be hungover the next day, but they won't get any of the positive effects like that buzz or that melting away of the problem. So they'll consume alcohol a few times, and then most of them will get to that point where, why am I doing this? I'm not getting anything beneficial from it. And that's a good indication of how many people self-medicate with alcohol as well. So which of those are the best treatment options? Obviously, they all have pros versus cons. And you know, the best thing to do from the ED is just stabilize them and get them into a treatment facility. And typically, it's going to be the partial agonists or the antagonists that are going to be the best ways to do that. Outpatient management, and many emergency departments across the country have something called a warm handoff. What's that mean? That means where you see them in the ED, you diagnose them with opioid use disorder or alcohol use disorder or whatever it is, you start them on those stabilizing medications, and then you hand them off to a treatment facility. So for opioid use disorder, those warm handoff medications are mainly going to be Suboxone, maybe some Subutex if you have some pregnant females, okay? And it's gonna look like maybe a 3-day supply with instructions on how to take it, et cetera, and then providing the resources, you know, for them to get into a treatment facility. For alcohol use disorder, this is something that we encounter in the emergency department all the time, and it's always been so challenging. For the one thing that you guys all understand is the way that we prevent alcohol withdrawal seizures and DTs is by using benzos. Well, benzos are a respiratory suppressant. If that person were to go home and be taking those benzos and halfway through, you know, day 2, they decide, oh, screw it, I'm going to drink some alcohol. Well, now that's a fatal combination. And as the prescriber of that benzo, you could potentially be on the hook. There are some ways around that, and we're going to talk about one of those ways here shortly, where you can use a fairly safe or relatively safe benzo like Librium, but you could also include a family member or a friend who has the patient dose with disulfiram daily so that they can't consume alcohol. And if they did, they would get violently ill and they'd end up in your emergency department. I also, the other things on here, I want everybody to understand those differences between Suboxone and Subutex. And also, you always do better when you're dealing with the patient in the emergency department. Just understand that it's already a bad day for them. You know, they're already there because some crisis is going on. I can promise you that if you treat them like garbage with stigma, that you're not going to turn their life around. I've never encountered a patient who was like, well, I was doing all these dysfunctional things and wrecking my life. Then I ran into this ER doc and, you know, he called me a POS and you know, threw me out of the room, and that was my wake-up call. These people have had a lot of wake-up calls before you know, came into their life. It's a lot easier when you just destigmatize and empathize, and you basically say, like, listen, man, these are the limitations that I have, you know, while taking care of patients in this emergency department, but I'm going to set you up for success, and I'm going to get you plugged in, you know, to a facility. You guys in Altoona, you have Pyramid, you have plenty of facilities nearby. In some locations, it can be tougher than others, but you're still going to get a better response from the patient, and you're going to feel better about it if you empathize and destigmatize. Okay, so we talked a little bit about alcohol. Some other things that need to be included in the management of alcohol. About 80% of ED docs do this, but some I think don't do it either because they don't want to bother with it, or because they're just not comfortable with it. I typically always include a banana bag because you don't know how bad the nourishment status of that patient may be. Hydration is a given, and then of course the prevention of seizures and DTs using typically benzos. And I'll give it through the IV, but if I'm sending them home, I'm using Librium and disulfiram or antabuse in combination to make sure that they don't have that synergistic respiratory suppression and death. And a lot of times that includes a family member who can do both. Take this disulfiram, okay, you swallowed that, okay, here's your Librium, and then whenever they see them 6 or 8 hours later to give them another Librium tablet, they can double check and be sure that everything is going smooth and that the person has complied and not gone and puked up the disulfiram and ingested alcohol or anything like that. Okay, so these are the other MAT options for alcohol. Librium and preventing DTs and seizures and that's not considered medication-assisted treatment. That's just considered the acute detox phase. Moving forward, though, with medication-assisted treatment options, which are more long-term, there's disulfiram or antabuse, which is specifically working on the alcohol dehydrogenase enzyme, which many of you know. Therefore, if they don't consume alcohol, it's not acting on any receptor or causing any kind of side effects or problems. However, you do have to warn them about all alcohol consumption, including things from like mouthwash or foods that may have been cooked using alcohol. Any little bit of alcohol will make them violently ill. Now, Naltrexone, we already talked about the mechanism of action of how that works. And then that leaves acamprosate or Camprol. And really the thing to just honestly say about that is we don't have a great idea of how that works. It's very much like certain medications, including, we have some antibiotics that we're not 100% sure on the exact mechanism of action. Well, Camprol is similar to some of those antibiotics and some of those non-SSRI antidepressants like your atypicals, where we're not exactly sure, but we know the effect that it has. I always tell people that Camprol and acamprosate is try to think of it similarly as Chantix for smoking. We give it, and a person has to take 6 capsules a day, 2 in the morning, 2 at lunch, and 2 at dinner. And usually within about a week or 2, they'll start to notice that their cravings for alcohol are getting less and less. So it's specifically working on cravings, much like Chantix, but doesn't have a whole lot of other mechanism of action, which also is similar to Chantix. Okay, outpatient management, we talked about all these things, include that family member. Don't be afraid to get creative. That's all I wanted to say. Thank you guys. I know it was probably a good 20 to 25 minutes, and you guys all have very important things to do. Thank you for giving me the opportunity to share some information. Hopefully you take that with you back to your emergency medicine practice, and hopefully it helps add in some way. If there's anything I can do, feel free to reach out to me individually. I enjoyed teaching. I enjoyed this aspect of medicine, which is, of course, why I pursued it as board certification. And I just appreciate everything that all you guys do. You've all been amazing to work with. Dr. Bouchard, you've been awesome as a medical director, one of the best I've come across. And I'm just happy that I've gotten to work with you guys for the past few years. So thanks again. Have a great weekend. And I'm here if anybody has any questions or wants me to do any additional talks on anything more specific. Take care.